I am going to start the recording now. So just so you know, the session is being recorded, not only for quality improvement, but we do post these on YouTube so that other people can learn from all of you. If you have not done so, please put your name and email address in the chat function. That helps our record keeping, helps me take attendance so that you can claim those continuing education credits. Please stay muted unless you're speaking. So that's going to be *6 on your phone or the microphone icon on Zoom. Please always feel free to post things in the chat if you are having any sort of audio internet connectivity problems. And in the spirit of Echoes, I'll teach, I'll learn, we will be on a first name basis during the sessions. So I am going to turn things over to Dr. Aga, and he can do any introductions that he'd like to do, or just get started with the presentation today.
Thank you very much. I think we'll just get started. Everybody knows everybody here, so that's good. First of all, just a moment of personal privilege. Thank you everybody for all your well wishes when I was unwell a few weeks ago. I really appreciate that. And it's great to be back and in one piece. So with that, I'm going to share my screen and we'll start talking about membranous. Now, a few months ago, Umar made a very comprehensive presentation on membranous nephropathy. So I'm not going to go too much into the details of the pathogenesis, and we'll focus solely on management in light of recent trials. There's been a slew of trials in the science of membranous nephropathy over the past few years. So we'll kind of look at that and then try to sort out how to deal with some of these cases. So I have no relevant disclosures for this particular talk, and just so that we all are clear, all patients in the cases that we will discuss, they have been appropriately de-identified. So this is a case that I had sent out. This is a 60 years old, previously healthy male who presented with nephrotic syndrome, about 12 grams of protein in 24 hours and a PLA2R antibody level of 270 relative units per ml, and preserved GFR, biopsy confirmed membranous nephropathy. So the question was how to treat this patient. I know I had started treating this patient and there were some questions about response and all that. So what we're going to do today is we're going to pause here. We're going to go to some aspects of membranous nephropathy, then come back to the case and see that in light of this, how would we want to treat? Ahad, would you mind sharing how you actually treated this patient? I think you said you had treated them with rituximab.
Can you guys hear me?
Yes.
So we treated this patient initially with steroids and rituximab. I think you will share the screen at some point. I think it's already showing the PLAR levels, isn't it? So we started with pulsing him with solumidrol and then giving him a dose of rituximab, 375 milligrams per meter square, and then repeating it after 2 weeks.
Okay, so you gave 2 doses of 375 milligrams per meter square. So you were following the Gem-Retux protocol. Okay, very good. So we'll kind of cover all of that. So this is a very good place to start. So membranous nephropathy over the past 10 years has changed quite a bit. Before Larry Beck's and Dave Salant's paper in the New England Journal of Medicine, I think in 2009, we used to call all membranous as primary or secondary. Primary was all idiopathic. We knew nothing of this stuff. And secondary was secondary to cancers, connective tissue disorders, drugs, infections. So if somebody had lung cancer, they could present with membranous. If they had lupus, they could present with lupus membranous. Several drugs were implicated. and infections like hepatitis B, hepatitis C, etc., could cause membranous nephropathy. But in 2009, when Beck and Samant published their paper about PLA2 antigen, then we started identifying target antigens of the podocyte, because we all understand, based on what Umar taught us when he was teaching us about membranous nephropathy, this is a disease of in situ immune complex formation. So the antibody is released into the circulation. It crosses the glomerular barrier and engages with the target on the subepithelial space, in the subpodocyte space. And once it engages the antigen in the subpodocyte space, these antibodies, being IgG4 types, don't engage complement through the classic pathway, but do engage complement through either the lectin or the alternate pathway, and that's how they damage the podocyte. So the first target antigen to be described was PLA2R, then THSD7, now NEL1, SEMA3B, and this is going to increase. So this idiopathic bucket is going to get smaller and smaller and smaller. Before 2009, all of these used to drop in the idiopathic bucket, but now we know that in the primary of the known targets, PLA2R is about 75% of the cases, THSD7 is about 5% of cases. There's a few NEL1s, few SEMA3Bs, and about 10 to 15 still remain unknown, but as time goes by, we will find them. So for the purposes of this talk, we are going to talk about primary. We're not going to talk about secondary. We're going to talk about primary membranous nephropathy. And mostly we are going to talk about the commonest type of primary membranous nephropathy, which is PLA2R. And then what we do is we transpose the lessons learned from PLA2R type disease onto some of the others and see if we can't treat them the same way. So the paradigm of development of membranous nephropathy is pretty straightforward. Antibodies generated. So we are using the example of PLA2R antibody. So this is an autoimmune, essentially, phenomenon. It interacts with the target antigen, leads to podocyte injury, and eventually causes podocyte death. So in its truest form, in its most simplistic form, the antibody starts circulating even before there's any problem. Then you start seeing some proteinuria, which then progresses to nephrotic syndrome. And then eventually you start seeing renal failure. And there's a progression of this. Now, we see all sorts of permutations. We see proteinuria and renal failure without PLA2R antibody, yada, yada. And we'll discuss some of those. But in its most pure form, you get the antibody, which then causes damage to the basement membrane, to the podocyte, leads to proteinuria, and eventually causes enough damage that you start losing GFR. So loss of GFR in membranous is a late phenomenon, just as loss of GFR in other podocytopathies like minimal change disease and FSGS is a late phenomenon. This is not a proliferative disease where loss of GFR is an early issue. So in this cartoon, what you're seeing here is the glomerular basement membrane. This is the epithelial. So this is the urinary space. This is the epithelial. So this is the podocyte. And the endothelial cells are going to be on this side. So you can imagine what's happening here. Your antibody kind of comes in and attaches to your targets, the PLA2 antigen or THSD7 or what have you, on the subepithelial space. Complement is fixed through either the alternate or the lectin pathway. Sublethal membrane attack complexes form and they start damaging the podocytes. Now, once they start damaging the podocytes, they cause disruption of the foot process barrier, and you start noticing proteinuria. The proteinuria can be massive, it can be non-selective. It usually is non-selective in membranous. So this is sublethal injury. So if you can fix this at this time, then all of this will get better. And so membranous is a slow ramp on, slow ramp off disease. So it's not like, you got membranous and in 2 weeks the kidney will be dead. It takes a long period of time, which gives us some time to figure things out and treat them appropriately. But you need to understand when to move fast, because if this continues for an extended period of time, then due to various mechanisms, you're going to have podocyte death. And there's only about 300 to 400 podocytes in each glomerulus. And if you lose about 40% of those, that's the magic number. If you kill 40% of these podocytes, then you've hit that point of no return. And at that point, no matter what you do, you're going to have progressive glomerulosclerosis. The glomerulosclerosis will be followed up by secondary IFTA, and your kidney will die. So loss of GFR, fixed loss of GFR in a patient with membranous is a very bad thing, because what that means is you've lost a lot of podocytes and you're likely going to have progressive disease. So although this is a slow ramp on, slow ramp off disease, early diagnosis and aggressive management can mean the difference between dialysis and no dialysis. And 30 to 40% of people who develop membranous nephropathy end up on dialysis in 10 years. It's not a benign disease, and it is a relatively young person's disease. So it is very much important to treat this aggressively. And since everything starts with antibody-mediated damage, we understand that there's a lot of immune contribution to this. So we have learned to treat membranous for the last 50 years now, pretty much, with immunosuppression. So any membranous that we think needs aggressive treatment is treated with immunosuppressive agents. So alkylating agents like cyclophosphamide or chlorambucil in yesteryears is a non-selective B-cell and plasma cell depleter. So that has been used. Calcineurin inhibitors immune modulate, and therefore they have been used. And then we've now developed directed B-cell depleting agents. Rituximab is the marquee agent for that, but there's others available. And so all of what they're trying to do is to kill some of these cells that make antibodies. So let's take a look at what we're seeing on this side of the picture. You got the B-cell progenitors, and then this is what's happening in the lymph nodes, the germinal center B cells, part of the germinal center reactions. And once the germinal center reaction happens, you either metamorphize into plasmablasts and plasma cells to make antibodies, or you go in and make memory B cells to generate a secondary response. Now, CD19 is a pan B cell antigen, so it is capped by all types, all stripes of cells of the B cell lineage. It thins out as plasmablasts convert into plasma cells, but it's still expressed. And as it's thinning out, plasma cells start picking up CD38. So just as B cells have CD20 and CD19, the plasma cells wear CD38. CD20 is picked up by pre-B cells, and as plasmablasts are converting into plasma cells, they lose CD20. Rituximab acts on CD20. There's now antibodies being developed against CD19. Cyclophosphamide will attack here. Bortezomib, for instance, is going to attack the plasma cells and plasmablasts, and daratumab is an anti-CD38 monoclonal antibody, which will just attack the CD38 positive cells. So depending on where you are and depending on what type of identity tag you're wearing, you can select your therapy. And then ACTH, both recombinant and natural, have been used, but we're not going to talk about ACTH too much today. Our focus will be on figuring out how to treat membranous using these three frontline agents. So this is the first and the most important trial that everybody's heard about in the science of membranous. So this was methylprednisone and chlorambucil in idiopathic membranous nephropathy by the famous Claudio Ponticelli. And the regimen that he used now is eponymously called the Ponticelli regimen, cyclical therapy. We all know this. So they had 32 patients in the treatment group, 30 patients in the control group. And what they did was, for the treatment group, they deployed a cyclical regimen of steroids and chlorambucil. So you would, on the steroid months, give a pulse of methylprednisone, 1 gram for 3 days. And then for the rest of the 27 days of the month, you would use oral methylprednisolone or oral prednisone, and that would complete that month. And then cycle B treatment was chlorambucil 0.2 mg per kg per day for the next month. So month 1, 3, and 6 would be cycle A, and 2, 4, 1, 3, and 5 would be cycle A, and 2, 4, and 6 would be cycle B. Chlorambucil would be dose adjusted if there was leukocytopenia. And the standard of care was deployed for the control group, which was essentially low salt diet, diuretics, and antihypertensives. This is pre-mass renin-angiotensin-aldosterone blockade days. So ACE inhibitors, which were barely getting into the market at that time, were not used uniformly. And so the results were as you would expect. In the treatment group, 12 patients had complete remission, 11 had partial remission, and 9 patients were unchanged. In the control group, 2 people had complete remission, telling you that even people with established disease can go into complete remission on their own. 7 patients got better, had partial remission, 13 were unchanged, and 7 got worse. 1 patient died, but that's just luck of the draw. It could have happened in any group. These are the inverse of the creatinine slopes. So this is worse, this is better. The treatment group did better at 12 months and 24 months compared to the control group. So what you're looking at here is improved amounts of proteinuria and also preserved renal function. Now, the assumptions behind the regimen, and I don't mean to knock Ponticelli and his team's approach. This is 1985 or 86, and at that time, this is what the conventional wisdom was, that once we add 2 different agents, it would lead to minimization of iatrogenic morbidity. They thought that the high-dose steroids, the steroid cycle, was almost free of side effects, and chlorambucil given in these doses would have side effects which would be mild and rapidly reversible. Obviously, did not bear out. We understood that this was a regimen which was involved and did involve some issues of iatrogenic toxicity. So understanding this, realizing this, Ponticelli revised his regimen. And now what they did was they studied chlorambucil and compared it to cyclophosphamide. So the steroid arms, months 1, 3, and 5 were the same, but instead of compared it to cyclophosphamide 2.5 mg per kg per day instead of the chlorambucil, or compared it to chlorambucil. And obviously cyclophosphamide doses were adjusted to white cell count just as we do. And likewise, chlorambucil doses were adjusted to low white cell counts as well. And it turned out that both in the rates of partial and complete remission, that was one endpoint, and complete remission was another, there was no difference between chlorambucil and cyclophosphamide. And so that kind of helped switch the Ponticelli regimen into cyclophosphamide and steroids rather than chlorambucil and steroids, and therefore now it is known as the modified Ponticelli regimen. So how is cyclophosphamide used in treating membranous? We use the modified Ponticelli regimen, which doses 2.5 mg per kg, but obviously adjusted for white cell count. There's a Dutch protocol where you use 1.5 to 2 mg per kg daily for 12 months, along with steroids in months 1, 3, and 5, a la Ponticelli. So you use the steroid, but you use the cyclophosphamide, slightly lower dose for a slightly longer period of time. And then you can use IV cyclophosphamide 15 mg per kg every 3 weeks. Not recommended, but there are some trials which show reasonable equivalence. And so I heard some thoughts in Pakistan. Oral cyclophosphamide is not available, so this may be your only option at that point. Now we're going to switch gears. So we've already talked about the alkylating agents, and we'll see how all of these perform in the modern era. But Gem-Retux was the trial which actually started putting rituximab on the scene for treatment of membranous nephropathy. So treating membranous with rituximab made all the intuitive sense. We know that there's an antibody that causes the problem. So therefore, why don't we cut down the antibody production, and that should take care of the problem. So this was a multi-center prospective randomized controlled trial from France. This was Pierre Ronco's group. And so what they did was they randomized 77 patients, 39 to conservative treatment, NIAT's non-immunosuppressive antiproteinuria treatment, and rituximab, whereas 38 were assigned just to NIAT. So that's the control. We won't be able to do a trial like this anymore, so we'll have to have 2 treatment arms. So this is the early part, so they were able to compare treatment to essentially conservative management. And so this is their protocol. So they would start including a patient. There would be a 6-month period of pre-randomization observation where they would optimize non-immunosuppressive antiproteinuria treatment. And this is very, very common in trials of membranous, because membranous sometimes tends to remit on its own. So if somebody was beginning to remit or had significant drops in their proteinuria, they would kick them out. If somebody remitted, obviously, they would kick them out. But if you had persistent nephrotic syndrome at 6 months observation, they would randomize you. So they would randomize you to non-immunosuppressive antiproteinuric treatment, which is essentially blood pressure control, renin-angiotensin, aldosterone blockade, yada, yada. Or they would give you 2 doses of rituximab, 375 milligram per meter square IV, 2 doses. Now keep an eye on this, because this becomes very pertinent. This is a slightly lower dose. Usually when we use rituximab in different types of diseases, we either use 4 doses of 375 milligrams or 2 flat doses of 1 gram each. But what Pierre Ronco's group did was to use 375 milligrams per meter square, 2 doses. So, and then what they did was they looked at what happens at 6 months. So they gated the data at 6 months. There was an observation period for 2 years after that, but the endpoints were gated at 6 months. So let's see what this trial teaches us about the science of membranous, especially when you're using rituximab. So what we saw was a very significant and statistically clearly beneficial response in the PLA2R antibody levels. You can see this is the baseline. It drops like a rock. In the controls, it comes down, but kind of stays quite high. So the PLA2R goes down. The albumin gets better. Kidney function is about the same at 6 months. However, the proteinuria, the remission, I'm sorry, complete and partial in the treatment group was in 24 patients, and in the immunosuppressive group was about 13 patients, and this was statistically significant. So the NICE cohort, the NICE group under Barbara Sykes-Polisky, which is another very active group in the science of membranous, looked at the Gem-Retux data, and what they did was they compared it to their own cohort. Now, the difference in the NICE cohort compared to the Gem-Retux cohort is that the NICE cohort takes 2 grams standard doses. So the intervention in the Gem-Retux group was 375 milligrams per meter square, 2 doses. What the NICE people got, and this is a retrospective review now, what they got was 2 grams, so 1 gram each over 15 days. And what they found was their remission at 6 months was 64%, compared to a 6-month remission in the Gem-Retux cohort at 30%. The time to remission was faster. So a lot of this, this remission that you saw in the Gem-Retux group started happening after the 6-month period in the observation period. But if you use the higher dose, you got to remission faster. Your CD19 count, so let's take a look at this now. So this is the NICE cohort, this is the Gem-Retux cohort, and this is the rituximab level in the blood. So essentially figuring out how many people were rituximab-emic at 3 months. And so In the NICE cohort, quite a bit of people had detectable rituximab levels at 3 months, whereas in the original Gem-Retux cohort, only one lone ranger is detectable. Pretty much everybody else has cleared their rituximab. Similarly, the CD19 count, as well as the anti-PLA2R, well, anti-PLA2R regimen antibody looks about the same, but still, you can see that there's a trend towards significance. Actually, this is significant at 6 months. So the higher dose definitely leads to a better immunological as well as clinical response. So coming back to the patient Ahad had chosen this dose, but perhaps this would have been a better ploy based on the data we're looking at right now. Then came the Mentor trial. So Gem-Retux kind of put rituximab on the map for membranous, but I think Mentor was a very well-designed trial that helped us understand how to use it better. So in Mentor, again, you had the screening phase, you had the conservative therapy phase, you're trying to weed out patients who are going to get better on their own. And then once we decided, okay, this person is going to be a good candidate for treatment, then they were randomized to rituximab or cyclosporin. 6 months observation period on treatment. So obviously they got the rituximab doses. Cyclosporin, and they were treated to keep levels between 120, 12-hour trough levels between 125 and 175 nanograms per ml. So now what they did at 6 months was they reevaluated the situation. If the patient had no response, no change in proteinuria, nothing going on, they would call it a treatment failure in both arms, and then they would exit the study. So if you're not responding, you're out. If you had a partial response, right? So if you've dropped your proteinuria some, but you're not in complete remission rates, they would give you another jab of rituximab or continue treatment for another 6 months with the cyclosporin. So now they're going to bring you down to 12 months. So at 12 months, they would censor the data, but continue observation in all cohorts. Obviously, these guys are out, but in all the treatment cohorts, they would continue observation for another 12 months. Also, if you had a complete remission, so you see, if you had no remission, you're out. If you had a partial response, you're continuing treatment for another 6 months. But if you had complete remission, then they would observe you to 12 months and then observe you for another 12 months. So you're being observed total for 24 months. And so this was designed and powered as a non-inferiority trial. It wasn't designed to show that rituximab was superior to cyclophosphamide. It was designed to show that rituximab and cyclosporin were about the same, okay? Now, so what we saw was that at 6 months, number of patients with remission in the rituximab arm was 23. In the cyclosporin arm was a little bit lower, a little bit higher at 32. But let's see what happens as time goes on. At 12 months, the numbers are reversed. At 18 months, this is solidly getting better, or at least the same. This guy, on the other hand, is getting worse. So essentially what you're seeing here is that once you've stopped treatment at 12 months, you're beginning to see relapses. So cyclosporin is not looking too good. So rituximab at 12 months was non-inferior. So your confidence intervals are spanning this, but it's still showing a trend towards superiority. But solidly, we can say that at 12 months, rituximab and cyclosporin are the same. Rituximab is not inferior to cyclosporin, which was the primary endpoint. But at 24 months, clearly there's not even a contest. Rituximab seems to be better. So the lesson we learn here is cyclosporin maybe races to a response a little bit faster, but as soon as you stop treatment, you're going to start having relapses. And this is the lesson that led to the design of the Starman trial, as we'll see in a second. But rituximab starts a little slow, but then it maintains. So you can see that at 12 months, after that, there's not much change, right? There's probably one relapse, but it's kind of held steady after about 12 months. But you're not going to see the full response of rituximab or the full potential of rituximab till about 12 months. And my experience is sometimes 12 to 18 months is the window where you derive maximum benefit with rituximab. And like I said, it's a slow ramp on, slow ramp off disease. So imagine what is happening over here. What is happening over here with any of these immunosuppressive medicines is that you will, cyclosporine might be a little bit of an outlier for that, so we'll keep cyclosporine out. With rituximab or cyclophosphamide, what's actually happening is that you're killing the immune cells, the B cells, you're depleting them or you're rendering them anergic, and then you're dropping the PLA2R antibody level, and then the basement membrane and the epithelial cells, the podocytes, are begin healing themselves. So the antibodies start falling off, the complement activation starts going down, and the podocytes start healing themselves. So that process takes time, and it doesn't happen overnight. So this is the Mentor trial. Starman. So when people thought, well, if you're putting them on cyclosporin and they're having relapses, why don't we do something different, right? So the good thing about this trial is it's for the first time. So Mentor, you're comparing rituximab to cyclosporin. So it's like, you know, kicking a cripple. Cyclosporin we know is kind of modest as far as its effect on in membranous is concerned. But when you come to Starman, what they're doing is they're doing sequential therapy with tacrolimus and rituximab, and comparing it to cyclical therapy with corticosteroids and cyclophosphamide. So this is essentially a Ponticelli, modified Ponticelli regimen approach. So again, you're gonna screen your patients, run them through an observation period of 6 months, and at that point randomize them. The randomization was 1-to-1, which is what it should be in a trial like this. And what they did was they included people at this point who had proteinuria more than 4 grams, and their GFR was preserved at 45. Because, you know, I told you that with membranous, if your GFR is low, then no matter what you do, the patient may progress to end-stage kidney disease if they've had critical loss of podocytes. So in this particular situation, we want to include patients who've got potential for recovery, so preserved GFR is important. So they randomized 43 people in each arm. Only about 77 odd patients were positive for PLA2R of the patients where a serum was available. So now TAC was maintained for 6 months and then tapered over a period of 3 months. So everybody was off TAC by about 9 months. The targets that they used were 12-hour trough targets of 5 to 7 nanograms per ml. And the cyclical therapy was pretty standard and was completed by about 6 months. At 6 months, when you started tapering the TAC, a gram of rituximab was given. So just 1 gram of rituximab was given, right? So now you're using TAC, which is weak T, and a low dose of rituximab pretty late in the game, and then you're censoring data at fairly rapid time points. Let's take a look. So at every time point that they mentioned, measured till about 24 points, the cyclical therapy was superior to the sequential TAC and rituximab. So this is the proteinuria rates in the cyclical therapy, and the light blue here, so this one is the PLA2R antibody level. So what you're seeing is the PLA2R antibody level drops, and this is the proteinuria that drops. Now I want you to take a look at what's happening with the PLA2R, which is in this olive type color here. The PLA2R level in the TAC group is actually, it's not statistically significant, but the median levels are much higher in the TAC group compared to the corticosteroid group. And so the albumins again go up, but the cyclical group is superior, and GFR cyclical group looks better at all time frames. So the immediate conclusion from this was that sequential therapy is inferior to cyclophosphamide and steroid cyclical therapy. And based on the data, that's what it looks like. But I wonder if they had given the rituximab here in full dose and then kept the tack on and weaned the tack off at about 6 months, then we may have seen something different. So I always look at Starman with a little bit of a pinch of salt. We are sort of comparing apples to oranges. I still feel, and this is my personal opinion, that Starman could have been designed a little bit better. Now, Mene-Cyclo, rituximab cyclophosphamide, is a true head-to-head trial in patients with membranous nephropathy who are being randomized to either rituximab or to the cyclical regimen, Ponticelli regimen. So let's take a look at the plan of the trial. Again, screening period where you're maximizing converting conservative therapy. You want to make sure you're weeding out all the self-remitting patients, and then you're randomizing them. So the dose of rituximab is 2 grams. So 1 gram at day 1 and 1 gram at day 15, which is our usual practice. This is the intervention in the rituximab group, and then you place them on a typical Ponticelli type regimen for 6 months. That's the intervention in the cyclical group. Everybody gets NIAT per standard, and they're followed up at 36 months. So let's take a look at what we learned from this trial. So in the blue here is the rituximab arm. In the red here is the cyclical regimen. So cyclical is Ponticelli regimen. So what you're seeing here is that the PLA2R antibodies go down. I'm sorry, the proteinuria goes down in the cyclical regimen a little bit faster, as we would expect, and then the rituximab catches on. So at 24 months and at 36 months, there's essentially no difference in decrease in proteinuria. Similarly, albumin starts going up a little bit faster in the Ponticelli arm, in the cyclical arm, but then eventually at about 12 months, rituximab catches up, and then things are about the same. So again and again and again, what we are seeing here is that Ponticelli works a little bit faster, but eventually rituximab catches up. But I would caveat this, and so let me just finish the outcomes, and then I'll come up to the caveats. That this is Kaplan-Meier estimates of complete or composite remission, and they're essentially the same at all data points over the first 24 hours of observation. 24 months of observation, I'm sorry. Now let's take a look at this anti-PLA2R antibodies. So this is in the rituximab arm. You're comparing what happens to the PLA2R antibodies. So look at where they're starting. They're starting at 60. Look at where they're starting here. They're starting at 60. So the median cutoff that they had was about 58 RU per ml. So that's a fairly low PLA2R antibody level. So in this group, you would see a very, very fast drop in the PLA2R antibody. And after that, it stays low for the duration of observation, proteinuria coming down, and it stays fairly well controlled for the duration of observation. Again, in the cyclical regimen, it comes down, takes a little bit longer than rituximab in these cohorts, but then the proteinuria comes down and stays low, just as it does in the rituximab arm. So on the right panel here, you're seeing patients who did not have PLA2R antibody levels. Some of them were randomized to rituximab, pretty much mirror image of what you're seeing here. If anything, the response is a little bit faster, but we don't know if the level was high, low, or what have you. This is not that the antibody was negative, it was that we didn't have the specimens at all. And similarly, a mirror image of this on the cyclical regimen as well. So the caveat that we need to remember in both these is that rituximab is is performing just as well as the cyclical regimen, but this is an easy group to treat, in the sense that the PLA2R antibody is not very high and the GFR is well preserved. But the principle in the Mene-Cyclo was that rituximab and cyclical therapy performed quite well, equivalently well in this cohort. So this was at odds with the conclusion that we had in Starman, but again, the dose of rituximab was different in Mene-Cyclo. So we come back to the case. So this is again Ahad's case, 60-year-old gentleman, presents with nephrotic syndrome. PLA2R antibody level was 270, so fairly high level of antibody. Biopsy confirmed membranous nephropathy. How would you treat them? So he was treated with pulse steroids and 2 doses of rituximab at 375 milligrams per meter square. So now we kind of are going to have some interaction here. What do you guys think? Would you do the same thing based on the data, or would you do something different? Ahad, you've looked at the 3 or 4 studies that we've talked about. What do you think? Would you do something different now? Would you still do the same thing?
So thank you so much, Dr. Aga, for that wonderful presentation. I think this sort of clarifies quite a few things for me. I think when I described the case on the WhatsApp forum as well, I think most of the colleagues did say that we have to go for 4 doses rather than 2 doses. So my main worry is, especially our main worry in Pakistan, is rituximab is quite expensive. So before I wanted to go for the 3rd dose, I just wanted to make sure what the my colleagues thought. So my impression from what I learned from my colleagues and from you is that I would definitely do the full 4 doses, because the PLA2 levels had come down, but they hadn't come down to the normal level. The GFR was preserved, but the protein urea was still around 6 grams. Initially, the protein urea was at 24 grams. So it had come down significantly, but it had plateaued there. So I would definitely consider doing 4 doses in such patients. What actually happened with this patient is actually quite another story, because it's most unfortunate. That what happened was that before we were going to plan the 3rd dose of rituximab, the patient suddenly dropped his blood pressure. And his blood pressure became 90/60, and he was complaining of restlessness. He was admitted, and it showed that he had a high troponin level at that point. As a result, heparin was started, and the patient was stabilized with heparin. Cardiology saw them. The echo wasn't that bad, but the very next day, suddenly he lost consciousness and bled into his brain, and unfortunately died the very next day.
Yeah, I'm very sorry to hear that, but understand these patients are always sick. They're always at risk for infection. And that's always the thing that we have to worry about, where someone who's being treated with these immunosuppressive agents, I mean, maybe he got septic, who knows, but there would be these accidents. And, we are always cognizant of these, but at the same time, we don't let a bad outcome paralyze us. Now, the other comment I would make about this patient is that if we are going to treat membranous nephropathy de novo with rituximab, then we probably don't need to use steroids. That may add up to be too much immunosuppression in a situation like this. And so what I would suggest is, instead of bringing them back for 4 doses, we could probably get away with 2 doses of a flat, 1 gram each, and no steroids, and then follow. And it takes, we looked at the Mentor data, and we looked at the Mene-Cyclo data, and even the Starman data. It takes some time, and we'll look at a little bit more data as we go along in the course on how to actually follow these patients once we've actually deployed initial immunotherapy. So the management decisions that we have to make is when to start treatment. Not everybody needs to start treatment straight away. As you saw in all of these trials, that there's a period of wait. So we have to kind of figure out when to start treatment. So you don't want to wait too long. You don't want to let that kidney cook as you're waiting to start treatment, but at the same time, you don't want to start treating a disease which may remit on its own. Then the question is, how do you use PLA2R antibody in this? And so we'll get some data and discuss some of that. And the timber is, how is the patient himself? I mean, is he actually worth treating with immunosuppression or not? If they've got a lot of other comorbidities, very high risk from an immunosuppression standpoint, then you have to kind of figure out which regimen would be the best for them. And so that's kind of where the art of medicine meets the science of medicine. And that's kind of what's going to bleed into the regimen. You have to do risk stratification, the traditional risk stratification, and then modification of that based on serologies. And now we combine some of these approaches. And then the last question, which is very pertinent from Ahad's standpoint, is how do you stop treatment? How do you get off the titer of the tiger? When's the time to say, okay, I've given this patient enough and now I'm not going to wait and watch? So let's take a look at this. So this is the paradigm of this disease as it is emerging. The anti-PLA2R antibody gets positive, then you start seeing proteinuria. And just as the PLA2R antibody comes in before, the immunological activity starting before clinical activity, the immunologic activity actually stops before there is clinical response. So the PLA2R antibody starts going down before you would see meaningful decreases in proteinuria. And around this time, at some point, you'll see PLA2R in the glomerulus. Sometimes you'll see PLA2R in the glomerulus and no antibody, which can be very frustrating. And this usually happens at either end, either when the disease is ramping on or when the disease is remitting. So we'll kind of talk about how to do some of this when we're talking about our serological approaches. Now, an important thing to realize is that the PLA2R antibody levels drop. So this is month 6, this is treatment has started. So it doesn't happen within days. It doesn't happen within, weeks. It takes a few months, no matter what regimen you're deploying. It happens the fastest with cyclical therapy and happens the slowest with rituximab, but it does go down. But when it goes down, it takes usually about 3 to 9 months is the window where you're going to see PLA2R antibody levels going. But the proteinuria lags behind, so you'll see some decrease in it. But in the 3 to 9 month period, you're still seeing proteinuria going strong. So I wouldn't lose hope. It doesn't mean that you've failed, it just means that the kidney has not recovered yet. So proteinuria can take anywhere from 3 to 12 to 18 to 24 months from the time the antibody goes away to heal itself. And there's some times when there's a secondary FSGS type lesion that has already developed that, you'll have complete immunological response in a gram of protein, which you can just put them on an ACE inhibitor for, but it doesn't mean that you've failed in your clinical response. Now, in most of these trials, just to kind of stay faithful to the trial itself, complete remission is defined as a drop in proteinuria less than the 300 milligrams per gram threshold. But this is extremely important, that PLA2R drop is not instantaneous. It takes some time, and then proteinuria lags behind the PLA2R antibody, and it may be a several month lag. Second thing, so this is a study by Raganenti et al. From Italy. Now you divide PLA2R antibody into tertiles, and the tertiles are low, which is 14. 14 is usually the cutoff at the Euroimmune assay, 14 to 86, 87 to 204, and greater than 204. So lowest tertile is 14 to 86, which is kind of where both Mene-Cyclo and Starman were. The middle tertile is 86 to 204, and greater than 204 is the highest tertile based on the Euroimmune ELISA. And I'll tell you why I'm stressing the test, because you have to pay attention when you're looking at these studies of what test that was used, because some of these tests can't be transposed from one to another. And your chances of getting a remission out of rituximab are the highest if your antibody level is on the lower side, and the lowest if your antibody is on the highest side. So this is the group which the antibody levels were more than 204. Their chances of getting into a complete remission are lower. This is the group where the antibody level was 14 to 86. Their chances of a response are higher. So higher the antibody, it seems like there would be some difficulty in getting a response. And there's very good biologic explanation for that. There's something called epitope spreading, and we're not gonna, get into that at this time. But when you have high antibody levels, you may have some differences in the characteristics of the antibodies themselves. But suffice it to say, level of PLA2R antibody actually tells you what your patient is going to do. It also tells you which patient to wait and which patient not to wait. And so if you've got a fairly decent PLA2R antibody level, it's not going to remit on its own. So there's no point in subjecting them to a 6-month wait time. Go ahead and treat them. Now, if you're able to deplete the antibody, it's kind of intuitive, same group. If you're able to deplete the antibody with rituximab, then you're going to have a clinical response, which kind of follows the paradigm. Now let's take a look at this paper. This is from the Dutch group, and essentially these 3 bars are cyclophosphamide. These 4 bars are rituximab. And so again, the antibody levels are pretty similar to what Raganenti and company had. Low levels, 15 to 84, intermediate level, 85 to 151, and high level PLA2R, 152 to 776. Same 3 groups here, plus an additional group of 1350 to 2900. So very high levels. And the test that they've used in this retrospective data review is the Euroimmune assay. So let's take a look at this. Blue means good, we have responded. Red means bad, we have not responded. So here they're treating with cyclophosphamide people who've got antibody levels between 15 to 84, and you're looking at response rates of 90%. Same cohort of people. This is retrospective. This is not a randomized trial. So this is, you have to take it with a pinch of salt. So I just want to make certain that you understand what you're looking at. So here you're seeing about response rates of about 80%, so not bad, but about 20% are not going to respond. Middle band, pretty similar story. So if you've got antibody levels of up to about 151, rituximab is going to cause a remission in about 75% of the people, cyclophosphamide in excess of 80% of the people. We know that. If you go higher on the antibodies, if your antibody is 152 here to 776, cyclophosphamide still is going to drop a remission, and we're talking about serologic remission in about 80% of cases. It's going to drop the antibodies in about 80% of the cases. But let's see what happens with rituximab in this group. In this group, rituximab is going to drop only 20 to 30% of patients. So that's not good. And if your antibody is really, really high, rituximab is not going to touch it, right? So this again is not a randomized controlled trial, but it is making the same point. So let's see how some of our newer studies behave in this circumstance. So this is data from Mentor. I fished it out from the supplemental data that accompanies the paper in New England Journal. So again, the first thing I would like to point out is that the antibody assay that they used is not the Euroimmune assay. This was some company in the UK that was making the assay at that time. So all of these were sent there. So this does not talk to the Euroimmune assay, and these numbers are likely higher than what the comparative or corresponding Euroimmune numbers would be. But be that as it may, in the patients who had no response, the antibody levels were much higher compared to those who actually at least dropped their proteinuria by 25%. So there's a significant difference in the antibody levels, and this is true in both treatment arms. So cyclosporin, again, antibody levels much higher in people who didn't have a response compared to those people who did have a response. So again, we're looking at the same thing, that when you have high anti-PLA2R antibody levels, you're looking at badness, and probably these are people who need to be hit a little bit harder. This is the Starman data. So baseline numbers in non-responders, your baseline antibody is 106 compared to an antibody level of 64. Now, this is not significant based on the numbers that you have, but you're looking at the trends here. So again, it turns out that if your antibody levels are higher, your chances of response start going down. So how do we approach this based on serology? So this is one approach that was published in JSON a few years ago. So you look at antibody proteinuria, you look at GFR, right? So those are your three things that you worry about. Now, if you've got a very high PLA2R antibody titer, you're following the titer closely. If your titer remains the same or starts going up, you're going to start immunosuppression. And then there's caveats, unless your GFR is already down, right? Obviously, nobody in their right mind is going to start immunosuppression if there's a concomitant infection or something, but this is very important. Sometimes I see people give these patients cyclophosphamide and their GFR is 15. I'm like, man, that's not good, right? You want to make sure, and why is this important? This is, so this is, you'll never see this in lupus, right? You want to treat lupus, but in membranous, when your creatinine is above 2.5, 3, that tells you that a lot of podocytes are dead. So no matter what you do, you're not going to bring that thing back. So just always be mindful of that, and don't, this would be in the bucket of primum non nocere. Don't do any harm first. Now, if you had very high titer and the titer starts dropping, you continue to follow it. But my feeling is, if you've got frank nephrotic syndrome and titer is decent, you'll probably end up treating them anyways. So you'll need to start immunosuppression. Then you have to decide what is the best immunosuppression regimen for this particular patient. On the other hand, if your titer goes down, nephrotic syndrome is getting better, you continue to follow it. Maybe you can just treat them with non-immunosuppressive therapy. Now, if you have non-nephrotic proteinuria, titer starts going up, you're probably going to start immunosuppression, because if the titer is steadily going up, you're going to get into trouble. But if the titer is stable or going down and it's non-nephrotic proteinuria, you continue to follow. So it's all intuitive, right? If you're having high level of immune activity and the kidney is hurting, you're probably going to treat them. If your immune activity is getting better and the kidney is stable, then probably hold back and see how things turn out. And then how to get off the titer. So this is one way, same group. You've started immunosuppression now, you're following the PLA2R antibody. They check it bi-monthly. I check it every 3 months, so you can pick up your own flavor. If you've had a fairly rapid response and within the first 6 months, there's a 90% reduction in immunosuppression, you can probably start pulling back. On the other hand, if you've got no response, then you'll probably reinforce or modify your immunosuppression. And if you've got a slower response, so this is the mentor, some response but not quite group, you'll continue treatment for another 6 months. I recently saw a patient who had been on tacrolimus for 5 years and then been in remission for 4. So, you don't want to do that. You have to take immunosuppression off at some point. So this is my approach to membranous nephropathy. So this is, caveated, this is primary membranous nephropathy, usually PLA2R antibody, because that's where we have the most data. But we can extrapolate some of this to THSD7. I have no experience treating NEL1 or SAMA3D as of yet. So if you're really, really low risk and your PLA2R is negative, and when I say risk, I mean eGFR is preserved, there's not a lot of chronic change on the biopsy, proteinuria is not terribly high, you would want to just put them on an ACE inhibitor or an ARB and watch their trends. If your PLA2R is low titer and they're low risk, then I would watch, but I will keep following the PLA2R titer closely, and if it starts going up, I'll probably end up treating them. If the PLA2 titer is high and they're low risk, I know that they're not going to remit. I'll probably put them on rituximab. If the PLA titer is very high, or if they're high risk, then I would put them either on a hybrid regimen, so some form of combination of cyclical therapy or combination therapy. So the combination therapy flavor that I use, and that is my practice, it is not backed by a lot of data, is a slight tweak on the Starman, that I put them on a calcineurin inhibitor to see if I can get them into remission a little bit faster, but dose the rituximab upfront. So those are your various buckets in which you can put these patients. So based on that, we come to the next case. This is a 50-year-old male with gastroesophageal reflux disease, hyperlipidemia, presented to the clinic with 8 months duration of lower extremity edema, found to have nephrotic syndrome, had 10.7 grams of protein. Albumin was not 2/4, but 2.4. I'm sorry about the typo. Creatinine was 1.3, and the PLA2R antibody was 170 relative units per ml. He actually refused a kidney biopsy. And he had been symptomatic for about 8 months. So how would you guys treat them? What is, after going through this diatribe of cases and data, what is the consensus? Who would choose Ponticelli, and who would choose rituximab, and who would use a calcineurin inhibitor? Anyone? Any takers? Umar, my friend, what would you do?
Is Umar here? I mean, Farooq, Dr. Umar Farooq?
I don't think he's here. Yeah.
Okay, well, Aves, you spoke, so you're it, my friend. What would you do?
No, actually, I had a question from him. I mean, he gave a very good presentation about a patient who has very, very high level of PLA2. And I was wondering, how did he treat that patient with rituximab or with cyclophosphamide? Yeah. So this patient, basically, this patient definitely needs treatment. So I would definitely start him on rituximab, not cyclophosphamide. Based on that, his PLA antibodies are high, but not super high. I know his creatinine also. I don't have his baseline creatinine. What was baseline creatinine?
1.3. So it is a little normal, yeah.
So I would treat him with rituximab 1 gram, 2 doses, 2 weeks apart. So no steroids.
That's precisely what we did with this patient. So he presented with about 11 grams of protein. So these red bars are the PLA2 antibody levels. The blue line is his proteinuria. We dosed him with rituximab in November of 2020, somewhere around there, or October or November of 2020. And so see, this is the clinical course that's pretty typical in membranous after you dose rituximab. So for the first 2 or 3 months, you see pretty much nothing, but you do see some serological improvement, right? So the PLA2R antibody is going down, then it's going down further, and it's gone down completely. And then you start seeing, as you're seeing immunological response, you start seeing the clinical response, the proteinuria is going down. So we're still treating him. We actually gave him a second dose of rituximab based on the mentor protocol. So remember, mentor, if you've not had complete remission, but you've had a partial remission by 6 months, they'll give you another dose. So we gave him another gram of rituximab. His proteinuria is down to about 2.5 grams or so now. And we're anticipating that he's going to continue to improve and get rid of the proteinuria in the next few months. So you just have to be patient. His CD19 count, it actually doesn't show up because I chose the scales not well. But at 3 months, I check CD19 count in all these patients. In about 20% of the cases, you'll find that the CD19 is not completely suppressed. And in those patients, I might give this second dose a little bit sooner to drop them down completely. But in his particular case, at 3 months, his CD19 count was undetectable, which is what you want to see in this case. So this is presented as a fairly standard case of how rituximab affects him. So he was dosed in October, November last year. So I'm thinking by October, November this year, he would have reached remission levels. And then this hopefully will be a durable remission and we won't have to do anything different to this guy. All right.
Apologies for interrupting, but there were a couple questions that came in the chat, and I wasn't sure if you had been able to answer them.
Sure. Let's kind of bring them up or.
Sure. So Dr. Aziz had said, how do you classify PLA2R antibody levels into the 3 GPS in numerical values? And then I believe was answering your question about what dosing you would give for the case that you presented.
Yeah, so the 3 groups generally, for the sake of convenience, remember 14 to 80, 80 to 160, and more than 160. Some people do 0 to 100, 100 to 200, and more than 200. This is based on the Euroimmune assay. So just be cognizant of what assay you're using. This is, I think, the question Dr. Madhiya Aziz had asked. And then the dose of rituximab, what I use is 1 gram, 2 doses. Some people use a dose of 375 milligrams per meter square every week for 4 weeks. I just use the 2 doses because that's just simpler. When you're using a calcineurin inhibitor, if you're using tacrolimus, you want to target for a 12-hour trough level of 5 to 7. If you're using cyclosporin, you want to use a 12-hour trough level of 125 to 175. And when we say no steroids, we mean no steroids at all. So Mentor, there was no steroids given. So that's the chat questions. Is that it? Yes, okay.
Thank you.
All right. So coming back to case 3, 70-year-old white male, ex-smoker with COPD, history of prostate cancer and remission after treatment, presents with worsening lower extremity edema for the past few months. Creatinine is 0.9, urine with 4.5 grams of protein, albumin is 2.4, PLA2R is 70. Biopsy shows primary membranous nephropathy, PLA2R antibody positive. So how would people proceed in this particular case? Ahad, what would you do, my friend? Would you treat this patient? Would you watch him for a little bit? Would you use a calcineurin inhibitor, rituximab, or Ponticelli if you were to treat him? And please, guys, I'm just picking up on people I know who are there. Please chime in because this is meant to be an open-ended conversation. There's no real hard answers here. We just have, all of us have our own interpretations and how we do things. So there's no right or wrong answer. I'm interested in learning what your practice is and then sharing with you what mine is.
Well, I would wait and see this. I would watch this patient. I would just give an angiotensin receptor blocker for a little while, and I will watch the proteinuria levels and the PLA2 levels of the creatinine. I wouldn't start immunosuppression right away.
I think you're exactly right. I mean, the GFR is preserved. The proteinuria is in the nephrotic range, but relatively modest. PLA2R antibody is relatively low. The guy is a little bit of a high risk from various angles. So absolutely. So this is one of our live cases. We actually got the PLA2R antibody level like a week ago. So we have decided to check his PLA2R antibody and all of his parameters in a couple of months. And then if we find that the PLA2R antibody is going up, or if the proteinuria is 9 grams with the PLA2R antibody around here, then we will start treating him. And when we do decide to start treating him, our plan is to use rituximab in this case, because with his PLA2R levels at this time, he would be a favorable response based on Mentor as well as Mene-Cyclo criteria.
So, Irfan, question.
Yes.
So this patient with history of prostate CA, if would be very high risk, like his PLA would be 500, so it's pretty much contraindicated cyclophosphamide on this patient, right?
No, if the prostate cancer is in complete remission, then it won't be. To be honest, if and the thing is, and we're not talking about the non-immunosuppressive management of these patients, but anyone who has PLA2R antibody-related membranous, I still put them through a full cancer surveillance. And in this particular case, we have already sent him to his urologist to have a full evaluation to make sure that his prostate cancer indeed is in remission. Now, if the antibody level came back at 500, let's say, that's a good hypothetical, I would not be averse just on the basis of prostate cancer to put him through Ponticelli. However, he's 70, other things going on. So if I would be able to treat it with rituximab and cyclosporin for a period of time, or TAC for a period of time, I would strongly consider that as well. Does that make some sense? Okay. Next case is a 32-year-old male. Presents with nephrotic syndrome. Proteinuria is 15 grams. Albumin is 1.5. Creatinine is 1.1. Biopsy is consistent with PLA2R antibody-driven membranous. PLA2R antibody level was 2571 relative units per ml. So how would we want to treat this patient? Takers? Dr. Lane?
Okay, so let me start it. So this patient, a young patient who has very high risk for deterioration. I mean, he has PLA2 antibodies are very high. He's a nephrotic syndrome. So I think he's a candidate for cyclophosphamide and steroid.
Yeah. So that's what we started to do. And, just so essentially he was placed on Ponticelli. His PLA2R antibody levels are very resistant after 3 or 4 months of therapy. Actually, they went up to the 4,000 range. So we brought it, and he had refractory anasarca. So we brought him back for plasmapheresis to see if we could drop the antibody levels that way. He was placed on ultrafiltration along with high-dose diuretics. Unfortunately, he developed a gram-negative sepsis episode through probably his catheter, and he went into severe septic shock and passed away. So this is a cautionary tale that all of these interventions that we do can have very dire consequences. But yes, the correct treatment in this particular patient, and if this happened again, I will do it exactly the same way. We would want to treat it with the Ponticelli regimen. So this is a case which was shared by one of our Pakistani colleagues. I'm so sorry, I forgot the name. This was Dr. Atif Mohyuddin from Kashmir. He said that 35-year-old gentleman previously treated for membranous nephropathy with cyclotherapy, so received Ponticelli regimen, excellent response, so very well done. Now his proteinuria has increased from 200 to 600 milligrams. His PLA2R was negative, but now 18 relative units per ml. What would you guys do? Would you do anything? Would you start treating him again, give him another dose of rituximab or something? Or would you follow according to some form of a plan? What is the thinking?
I think it's only observation at the moment. PRA blood levels are not too high, and the proteinuria is not too high either. So I think conservative measures are the things to do.
Very good. I think that's exactly right, Dr. Aurangzeb. That's what I would recommend doing. Maybe follow his protein creatinine ratio every 1 to 2 months, check another PLA2R antibody level in 2 or 3 months. And if you find velocity in the PLA2R, so the next time it's 40 or 50, and the proteinuria is beginning to come up to 1 to 2 grams or something like that, then that would be a time to treat. And how would you treat it at that point? Let's suppose, for the sake of argument, we recheck the parameters at 3 months, and at that time the antibody level is 60, and he's got 2 grams of protein. What would you do at that time? Aurangzeb, you want to take it?
Yeah. Well, that's a googly. But the problem is It's if the patient is going fine and the risk and the benefits has to be discussed with the patient, and probably with 2 gram proteinuria, I may continue for the next 3 months still observing if the creatinine is fine. Because the patient has already has gone through the cyclical therapy, and at this point there isn't any discussion about the renal failure, and the proteinuria is still below the nephrotic range. Probably that's what I would do. I know that's controversial.
That's not controversial. I mean, that's as good an answer as any. Any other opinions on this? Anyone who wants to treat at this time?
I mean, this patient responded to cycle therapy. It's not a failure. So when you have failure, complete failure, you want to try a different regimen.
Right. So, Abes, the hypothetical here is that we're checking this in 3 months from now, and now the antibody level has gone from 18 to 60, and the proteinuria has gone from 600 to 2 grams. So at that point, Dr. Aurangzeb wants to watch for another little bit of time, hoping that it will respond on its own or remit on its own. But I'm just playing devil's advocate. I'm asking, is there anyone who would treat it at that time? 2 grams of protein, but the PLA2R is definitely showing an upward swing.
Well, Irfan Bhai, if I can ask a question.
Sure.
Regarding the last trial after Starman, I think Scorelli F, that was the trial, in which they compared cyclophosphamide with rituximab. I think they did not give any 6-monthly dose of rituximab for any partial responders. Is that correct?
That's the Mene-Cyclo. And yeah, so essentially they used 2 grams of rituximab upfront, and they used the Ponticelli upfront. There was no redosing.
Okay, but despite of no redosing, there was good response at 36 months. So does that bring us to the level that for all those patients who are having a partial remission and not having very high titers of PLAR in the beginning, there isn't any additional need of 6-monthly additional dose as the mentor has already suggested? Because this question is pertinent, especially in Pakistan, where the cost of rituximab is a major problem.
Yeah, so let me just, that's kind of a slightly different question. So the question we were asking for case 5, Dr. Mohyuddin's case, is what to do at this time. So I think we're all in agreement that at this particular moment in time, with 600 milligrams of protein and a PLA2R antibody at 18, which is barely detectable, we would probably want to do nothing and then just maximize non-immunosuppressive antiproteinuric therapy and wait and watch and maybe repeat all the parameters in 2 or 3 months. If at 2 or 3 months, the antibody level has gone to 60, so there's a linear increase in the antibody level and the proteinuria is increasing, I would actually at that time give them a dose of rituximab. That's what I would do. But what Aurangzeb says that he would want to wait a little bit further is pretty reasonable as well. But my thinking is that you're already looking at a clinically manifesting relapse. So the quicker you stem it, the better. But at the same time, Aurangzeb's concern is he's already had the Ponticelli regimen. Do we want to go prematurely on giving him more immunosuppression? There's no right or wrong answer here, but it's a difference in perspective. But my feeling is this kidney, if it has already been beaten up once, we want to decrease the amount of beating it gets the second time. Now, Aurangzeb's second question is, let me see if I can't get to Mene-Cyclo. Let's get to Mentor. All right. So this is the classic paradigm that we have begun using for rituximab, right? So if you've got at 6 months, you've got no response, you're like, we're done. The PLA2 antibody levels have not changed, although they were not following PLA2R antibodies and Mentor, but I'm just saying, and that the proteinuria has not improved at all. We have to do something else at 6 months. This is the Mentor thinking. Now, if you've had a complete response, that means proteinuria has dropped below 300 milligram per gram, then you don't need anything else. If you're kind of in the middle where you've had a partial response, which for the sake of these trials, is defined as a drop in creatinine below 3.5 grams, but not below 300, or more than a 50% drop in their proteinuria levels. So that's your partial response. And so they would retreat at month 6. So Aurangzeb's question is this necessary? Based on mentor, yes. If you're looking at low risk Mene-Cyclo type people, they're giving only 1 dose and they seem to be doing okay at 36 months. So it depends on what your philosophy is. My thinking in this is if your initial PLA2R antibody level was low, and this is my opinion, none of these trials are going to advocate what I'm trying to tell you. If the PLA2R antibody levels were low to begin with, and there's a fairly significant drop, so they had 10 grams, and now you're at month 6 and it's 1.5 gram, then you know they're getting better, and you might be able to run away with a single dose. On the other hand, if the PLA2R antibody to begin with was 500 or 300, and now it is 150, and they had 15 grams of protein, and have 4 grams of protein at 6 months, probably they will need a boost. Otherwise, they will either treatment fail or relapse sooner rather than later. Does that answer your question, Aurangzeb? But this is an opinion. I want to be very careful. This has not been tested in a trial.
Yes, I know that. But I think I agree with your opinion. That is how it should be done.
Okay. Any other questions, concerns before we conclude today's session? I'm trying to keep it.
Irfan, I have a question and an observation. Is the serum creatinine a function of on the basis of which we should make our decisions, or should we just base our decisions on PLA and proteinuria? Because I have a patient who recently, after completion of rituximab, weekly 4 doses, and 4 weeks after that, his proteinuria and creatinine suddenly started to rise.
Mhm.
So how long should we wait for Ritux to really show its effect vis-a-vis the serum creatinine?
Well, luckily we've got the graphic right in front of us. So this is the proteinuria that we're looking at. This is in the blue lines. You're seeing rituximab, and you can see that the proteinuria starts dropping, but it takes anywhere between 6 to 12 months to actually drop below the 2 gram level. So there's a lot of time that goes. And you'll see sometimes proteinuria splaying up and down. So it was 8 grams, and then it's 10 grams, and then it's 7 grams. Initially, there may be a little bit of splay, but then eventually it will sawtooth down, but it takes some time. It takes a little bit longer for rituximab, a little bit shorter time duration for the cyclical regimens, cyclophosphamide-based regimens, but eventually they'll get there if they're going to respond. And based on full treatment with rituximab or with a cyclical therapy, you can look at response rates somewhere between 60 to 80%. So to answer your question, it takes, it takes some time for all of this to happen. You're not going to see a response. This is not diffuse lupus where you give them a steroid pulse and the GFR starts getting better. Now, your original question was, should we look at the GFR? The only reason I look at the GFR, and by that I mean fixed GFR, is when not to treat them. If they've got good GFR, I would treat them. But if their fixed GFR is 30 or 25 or 20, I'd probably end up not treating that membranous because I'm not going to get them any benefit. Their GFR is 30 by the time it's 1.5 years and they're trying to get into remission. If they're going to ever get into remission, their GFR would be below 20 and they'll be looking to start dialysis. All I've done is given them immunosuppression for nothing. So these are the patients where you want to pick them up. So many of the trials gate your inclusion GFR at 30 or 45, and which is reasonable because that's where you should be treating them. That's where all of us should be treating them, because if you start picking them up to treat when the GFR is already 25, you're not going to get anywhere.
Okay, I have another.
Also, I would want to make a point that a lot of times The GFR is artificially up or down in these patients because all of these patients are on ACE inhibitors, they're on diuretics, they can get normotensive intrarenal dehydration. So when I say GFR, it's not a snap GFR, it's a fixed GFR drop. So if they, had a GFR of 60 and then we put them on ACE inhibitor and diuretics and their GFR dropped to 30, that doesn't mean much. That just means, we need to adjust their medicines a little bit. But if their GFR is fixed at 30 or fixed at 25 or fixed at 20, those are not the people you want to put through these toxic therapies.
So this is where I suppose one small question. When you have this cyclic therapy going on, so the months when patient is getting cyclophosphamide, what do you guys do on steroid during that time?
Steroids are off completely.
No, you stop or you taper off? How you do this? And you take a patient with 30, 40 milligram of steroid, you just stop completely?
The protocol calls to stop complete, yes.
You're not worried about that renal suppression during those days?
I haven't ever seen that happen.
Okay.
Lastly, I think there is a observation that we are doing at the moment for the patients who are having a mid titers and especially towards above 150 and 200. We are starting with 2 doses of rituximab and after that tacrolimus for 6 months. So it's still underway. We aren't really sure how will it go, but this is on the basis of observation that we had in the last 18 months. We came to the same conclusion, of course, that rituximab doesn't work that good if the titer is above 150.
Yeah.
So,
well, I wouldn't go that far. I've seen rituximab work very well in titers of 250, 300, 350, but chances are that you might not. So I still sometimes so I don't use a hard cutoff. I look at everything. I still sometimes give people rituximab when their PLA2R is a little on the higher side, but my inclination of changing course is faster if I see that they're not seeing a strong immunological response. But yeah, you can push the argument rightwards and say, okay, what if the PLA2R is 400? Yeah, true. At that point, I probably won't use rituximab monotherapy for these patients. And
So
the way you're using TAC with rituximab is exactly what I'm doing. And again, I want to make sure that everybody in the audience understands this has not been validated in a trial. I look forward to look at Dr. Afzal's results, but this is opinion based and this is a practice. It is not validated by any of the trials that we've talked about.
yeah. The problem in Pakistan at the moment is I started in one hospital and currently I'm transferred to another, and there isn't any rituximab funded by the government. So problems in Pakistan are of financial nature too. Just like Dr. Ahad, I am sure if there wasn't any financial constraint, Dr. Ahad would have given 1 gram 2 doses. But these 375 goes in a private sector, even that costs a lot.
These are definitely practical problems, and you have to kind of modulate your therapy based on the environment you're practicing in. But I would also add on the cost of 2 agents, steroids and cyclophosphamide, and then the lab following and so on and so forth. So, there's something to be said about that, but I do not know what the cost structure of rituximab is versus cyclophosphamide steroids. So, that's something that you have to modulate based on prevalent circumstances on the ground.
Yep. So just very 2 small points. So the first point is that I'm getting the basic idea that I'm getting is rituximab takes a while to work. So in the patient that I treated, within when I gave the first dose, the proteinuria actually came down from 26 grams to less than 12 grams. So do you think that could have been the rituximab, or do you think that might be the pulse steroids that I used? Number 1. And number 2 is that because oral cyclophosphamide isn't easily available in Pakistan, you've told about the Dutch protocol, which used IV cyclophosphamide 15 milligrams per kg. I've also actually put it in the chat box. In that case, how would you dose the steroids with that? Would you, because it's every 3 weeks, isn't it?
No, so essentially, just, the Dutch protocol is oral. This is oral cyclophosphamide.
No, just below that. So it says IV, but
Yeah, this is
how do you do that?
Yeah, so this is
Yeah.
an alternative. I mean, this is not, so the preferred way to give cyclophosphamide for membranous is oral. So you either use the modified Ponticelli or use the Dutch protocol, and these are both oral. You can, if you don't have an option, you can use 15 mg per kg every 3 weeks. So yeah, again, this is not within the confines of a trial, but if your back is to the wall, you can probably use this dose as cycle B instead of using the Ponticelli regimen or the the oral cyclophosphamide based on the Ponticelli or the oral cyclophosphamide based on the Dutch protocol. There is a trial which looked at this and it worked okay in that trial, but this is not your frontline therapy. So based on all the trials that are happening right now, you're using this as your cycle B. But if you have no option, if it's not available, then you have to do something, and this may work. But again, it will be best if all of you guys could get together, because each one of you are going to see 2 or 3 or membranuses a year. But if all of you guys could get together, you can actually have a case series in which you're using this as cycle B and maybe report those results. My feeling is it will probably work okay, but it's my opinion. Does that make sense, Ahad?
Yes, crystal clear. Thank you.
Okay.
Dr. Irfan, it's Dr. Mateen. So in this protocol of giving cyclophosphamide IV, we will continue with the steroids or not? No.
What you're doing is you're replacing this cycle B with an IV dose. And again, this is untested, but we are trying to adapt to what your requirements on the ground are, because did someone say that oral cyclophosphamide is not available?
Yes, in Pakistan it is not usually available.
Yes,
Oral cyclophosphamide is not available.
So your options are, and what about chlorambucil?
No, chlorambucil is also not easily available.
You have no choice but to try to use this, and that would be a fascinating case series if you can have 10, 15, 20 patients on this and see how that performs. That would be great.
Okay.
Any other questions, comments?
Thank you very much, Irfan. It was a great talk.
Yeah, thanks, Irfan. Thank you very much. It was very, very nice. Thank you.
Thank you, guys. Have a good day, good night, good afternoon.
Thank you.
Thank you, everyone. I just wanted to let you know, thank you for your engagement and participation as always. Those of you who've registered, you will be receiving our session evaluation email very shortly. That is how you claim continuing education credits if you choose. You can also make comments that we will pass on to our fearless leaders for this ECHO session. And we look forward to seeing you again on October 3rd. I believe Dr. Farouk will be presenting. And thank you all, and enjoy the rest of your day, week, and be safe. Take care.
Thank you very much.